you. Our
Thank
next
you.
panelist started a harm reduction rehabilitation center in Indonesia. Having had lived experiences with drugs, he merges this experience with professional training, creating a range of client centered services that include harm reduction outreach to meet the needs of people who use drugs. The center that he runs is called Rumah Singgah PEKA, which offers voluntary inpatient facility based treatment and community based outreach services. Everyone, let us hear from Sam Nugraha.
Good morning, everyone. Maybe it's getting more late in Philippines. I'm from Indonesia. I'm 1 hour ahead, no, later than you. So yeah, I'm not going to take so much time of yours. What I'm trying to share is basically how I do it and why I do it, and what works and not what working. So the I actually am in support of what Zach was mentions about the myth about addictions. He mentions earlier because it creates such a labels when people become addicted. It becomes like it's like what do you call it? Eternal disease or something that cannot be removed. What's important, I think there is a book that I usually use as the reference is the DSM-5. If you can relate with that, is the Diagnostic and Statistical Manual for Mental Disorder, which is, it mentions about the substance use disorder. So we see as the part of those who are developing disorder by using the substances. Not everyone who using substances will be treated it, but only for those who develop some disorders, which is it's only 11 criterias that you need to identify in the past 12 months. So you can, not. I think you can have a pictures about how to provide any kind of treatment or interventions, range from the very low severities, medium, and to the high severities. And as the result from our approach is basically a client-centered approach, which means we develop individual treatment plan, which is not a template. Not everyone who gets to the treatment will have the same treatment as everybody else. But we need to conduct a thorough assessment, and then we put that results into the individual treatment plans. So each treatment plan could be differ from one person to another. It can be very specific. And I would like to mention a bit about the TCs, as some of you might already recall. That stands for therapeutic communities. The TCs has changes since it was founded, I think in the 1950s, and then it just keep changing and try to adapt with the design. Although in my centers we do not using TC as the brand that came from the Daytop in the United States, but TC as a concept, which means the people who are choose to live there doing the treatment is part of the treatment itself for the other clients who are also living together in the treatment centers. So that kind of concept that we are using, as Zach mentions about modeling, the modeling also can come from their fellow peer clients to provide or give positive influence in changing certain behaviors that necessary in the treatment plan. And again, when we talk about these interventions, we often mentions about communities, and that community sometimes translated differently in different countries. While originally, when I was involved in the development of the UNODC guidelines for treatment plan, the community at that time, our definition is for those who are directly affected. Mostly is for those who are directly affected. That will give a strong message and also a strong impact for the people that we are providing services. But again, it's not automatically. Of course, need to be some guidelines that need to be followed. Make sure that nobody is in harms, even for those who are providing supports or receiving supports. And I would like to show you only a couple of slides about the result of our approach. The first slide is the one that we are using WHO quality of life. I think it's only 26 questions, if I'm not mistaken. As you guys can see, the WHO quality of life, it has 4 domains. The first domain is physical domain. The second one is psychological domain. The third one is social domain, and the fourth one is environmental domain. As you can see, the far left on each domain, I don't know which color on your monitors. In my monitor, it shows like dark orange. That is the one shows improving in 3 months period. So we assess the clients at the first admissions, and after 3 months we assess them again, this is a self-assessment tools that the clients can do by themselves. So it's quite significant. Mostly it's almost 50%. The physical domain is 48%, psychological is 52%, social 40%, and environmental 48%. The declining part, we have to admit that not every approach is working for every individual. That's why we have to put it individual. In our centers, we have limitations for a certain kind of clients. Then it shows it's declining from the approach. But again, the number is not really high compared to the one that improving. This is the one that we are referring to other centers or other services. And then the far right one on each domain is the static one, which is they're not improving, but they're also not declining. In every kind of approach, we experience this kind of number, that this number is we need to reevaluate, or we need to refer to other services that is more suitable with the client. And the other one of instruments that we are using, this is the last slide that I'm going to show you guys, is the Addiction Severity Index that is produced by Professor McClellan, and it's also being used by UNODC, and I think Colombo Plan Country is also using this. This is a 7 domain, as you can see, and pretty much the same. The illustrations, the far left one, or the bar on the far left one in the dark orange, shows the improvement. Now we can see they are on the first 3 domain. It's really interesting because mostly the number who are declining is higher than the one who are improving. This is the narrative is actually because before that they haven't had any access to health services, and then when they are being treated, and then they got medical checkup, and then they found out they have certain kind of illness that need to be taken care of. On the employment part, It's automatically because these were taken from inpatient clients. That means when they are in the treatment centers, of course, they are not working. But most on the drugs, on the legal aspect, the family, and the psychiatry domain, they are improving. So I think that is my slide. I'm not going to show you any slide. And I will leave more time for discussions, Q&A. I need back to you, Ali.
Thank you very much, Sam, for sharing your experience in your center and in your country. Concepts on individualized programs and therapeutic community are definitely important and something to look into for the Philippines in dealing with drug use, addiction, and recovery.